This is the second talk in our series, Advancing Cancer Prevention with Real-World Data. This represents a collaboration between all 5 persistent poverty centers. The 5 centers include the Acres Homes Cancer Prevention Collaboration, led by the University of Texas, the Cancer Awareness Research Engagement and Support Center, led by the University of Alabama at Birmingham, the Center for Social Capital, which is a collaboration between Weill Cornell Medicine, Columbia University Irving Medical School, and SUNY Downstate Health Sciences University, Hope and Care Together, which is a collaboration between the University of Utah and Montana State University, and the Upstream Research Center, which is a collaboration between Stanford, UC Davis, and UC San Francisco. We're very excited to welcome Rebecca Kehm today. She is an assistant professor of epidemiology at Columbia University's Mailman School of Public Health. She is a cancer and social epidemiologist. Her current research aims to identify modifiable early life factors that are associated with cancer risk, particularly early onset breast cancer. Her research encompasses a range of cancer risk factors, including social stressors, physical activity, and air pollution. She utilizes family-based cohorts to explore how these external factors interact with genetic susceptibility and employs biomarkers in breast tissue and blood to study risks throughout the life course. So again, we're very excited to welcome her. And Rebecca, I will let you take it from here.
Great. Thank you, Leslie. Let me just share my screen. Okay. Is everyone see the slides okay? Good. Okay, great. So thank you so much for that introduction. So I'm Rebecca Kehm from the Department of Epi at Columbia University. And I was kind of laughing when you read my bio because it's all about breast cancer. And today I'm actually presenting about liver cancer, so a little different topic. But I'm really excited to talk today about some of the research we've been doing here at Columbia, trying to uncover liver cancer disparities through area level mapping of hunger and hardship. And so my plan for today's talk is to begin by giving just a brief overview of the epidemiology of liver cancer, again, just to make sure we're all on the same page regarding the background on liver cancer. But then I'm really going to walk through 2 recent studies that we've been working on and published where we've leveraged real-world administrative and cancer registry data to examine social determinants of liver cancer disparities. So the first study that I'll be presenting on is an ecological analysis that we worked on looking at the association between county-level food insecurity and liver cancer rates here in the United States. And then the second study that I'll walk you through is an analysis where we looked at census tract level persistent poverty and liver cancer survival in the United States. And then I'll just very briefly conclude the talk by presenting on some ways that we can move from this evidence to action by presenting on a small community-based pilot intervention that we've been developing here at Columbia to address food insecurity among GI cancer patients. And between each of the studies, I can stop and take a few questions of clarifying questions about each of the studies, but then also I've left room for discussion and questions at the end of the talk as well. So liver cancer is the 6th most common cancer and 3rd leading cause of cancer-related deaths worldwide. The majority of liver cancers are the hepatocellular carcinoma subtype, or HCC. And as you can see by this map here with all of the red, liver cancer really affects all areas of the globe, including here in the United States, where it's currently the 6th leading cause of cancer death. What's really concerning is that we know that liver cancer incidence has been increasing over time. Here in the United States, the rate of liver cancer has tripled over just the last 4 decades. And due to this increase in incidence, as well as the fact that liver cancer has a very low survival rate with 5-year estimates of just 22%, for 5-year survival, it's projected that by 2040, liver cancer will jump from the 6th to the 3rd leading cause of cancer-related death here in the United States. And when we look at this increasing trends across different subgroups, you can see that this increase is occurring across different populations. So for example, in the top Left corner, you can see that the incidence is increasing for both males and females. Although you can see that males do have a substantially higher prevalence of liver cancer than females over time. Uh, we've seen an increase in all stages of liver cancer, so localized, regional, and distant stages of use have all increased over time, although with the greatest increase in localized disease. And if you look in the top right corner, when you compare Black and white populations, both populations have experienced an increase in incidence over time. However, I want to zoom in a little bit more about what's going on when we look across different racial and ethnic subgroups. As you can see here, when we look at more finer subgroups, you actually see that while for most subgroups there has in fact been an increase over time, this is actually not true for non-Hispanic Asians and Pacific Islanders, where we've actually seen a gradual decrease in liver cancer incidence rates over time in recent decades. And this is reflected as well in the mortality rates by race ethnicity, where for most subgroups you see an increase in mortality over time, although for the Asian population, there's actually been a gradual decrease in mortality. I also want to pause and point out that in addition to seeing increases and comparable trends over time, you do see that if you look at any point in time, there are significant disparities in the burden of incidence as well as mortality, where you can see that non-Hispanic whites have the lowest incidence as well as lowest mortality compared to other racial and ethnic groups. So when talking about disparities, it's important to look at trends over time, but also with any specific time period to look at absolute differences in rates. So what's going on? What's explaining this increase in liver cancer overall, but then some decreases in certain subgroups of the population? Well, there's actually quite a bit of work to show that we know that there's actually been shifting prevalences of the established risk factors for liver cancer over time. So it's well established that hepatitis B and hepatitis C virus is a risk factor for liver cancer. But we also know that there are lifestyle factors, including alcohol and smoking, that increase risk for liver cancer, as well as cardiometabolic conditions, including obesity and type 2 diabetes, that is associated with liver disease and ultimately liver cancer. And so the data has shown that over time, there's actually been this decrease in HBV and HCV related liver cancer due to increases in vaccination and antiviral therapy. And this explains likely the decrease in the Asian population that we saw on the previous slide. But at the same time, while there's been a decrease in virally related liver cancer, there's been a dramatic increase over time in liver cancers associated with alcohol, but also metabolic dysfunctional associated fatty liver disease, which has risen in parallel with the increase in obesity over time, again, observed here in the United States and in other parts of the globe. I do also like to point out, though, that it's estimated that about 40% of liver cancers are unexplained by known risk factors. So there certainly is still more etiologic research that's needed to really understand all of the drivers of liver cancer. Along these same lines, I'd also argue that there's limited or less research on the upstream social determinants of liver cancer disparities. So again, a lot of research and documentation of these racial and ethnic disparities in incidence and mortality rates, and a lot of work to show how lifestyle factors and viral infection and factors like that lead to an increased risk. But less is really known about how these upstream factors that can shape those underlying or more proximal risk factors could be contributing to these liver cancer disparities. And so again, when we're talking about social determinants of health, these include a range of factors, including things like economic stability, the neighborhood environment, education, healthcare access, the social environment, and the food environment and food security. And so our group was really interested in focusing specifically on this question of the food environment, of food security specifically, and whether food and food security may possibly be an upstream determinant of some of the liver cancer disparities that we're seeing in our data. So what do I mean by food insecurity? Well, the definition of food insecurity used by the USDA and many others is limited or uncertain access to nutritionally adequate, safe, and acceptable foods due to household economic and social conditions. And so I've bolded the word nutritionally here because I think it's important to recognize that food insecurity is not merely just the lack of access to food, but specifically to nutritious and healthful food that's needed for health and well-being. And in high-income countries like the United States, inequality is the main contributing factor to food insecurity, and this is why it's considered one of the key social determinants of health. So it's related to factors like income, high cost of living, health-related factors. There's a lot of research showing that individuals with chronic conditions and severe medical conditions are at increased risk for food insecurity due to competing costs, due to medical costs. And importantly, it's not here in the United States due to a lack of the amount of food that's available. So not related to famine or drought, but really due to access to foods that are currently available. It's estimated that about 14% of households in the US are food insecure. And you can see by this reverse pyramid that there is this continuum of food security in terms of the severity for which someone could fall. And it's also important to note that we know that food insecurity is not a static exposure. So an individual or a household can move in and out of food insecurity as their economic situation changes. We also know that the prevalence of food insecurity in the United States is also not static, and we can see quite clearly that it can shift with changing economic phenomena in a population. So, for example, you can see there was a clear spike in food insecurity after the financial crisis in 2008, and we see another spike following the COVID-19 pandemic. And just to further reinforce this fact that food insecurity is driven by other social and upstream factors, we see that there's a clear geographic patterning to food insecurity. So not all areas of the United States have the same level of food insecurity. And we know that certain household level characteristics put families at increased risk for food insecurity, including households with children, female-headed households, Black and Hispanic-headed households, and obviously those with an income below the poverty threshold are at increased risk for food insecurity. So again, just reinforcing this idea that food insecurity really should be thought of as a key social determinant of health. So what does all of this have to do with liver cancer? Why are we interested in exploring food insecurity as a predictor of liver cancer risk? Well, there's actually a number of plausible biological mechanisms through which we could think through food insecurity leading to an increased risk for liver disease and ultimately liver cancer. I actually adapted this schematic from a paper that was linking the mechanisms between food insecurity and cardiovascular disease. But I think it applies quite well to liver cancer as well, given that we know that cardiometabolic disease puts an individual at increased risk for liver cancer. So there's been a lot of work to show that individuals who are food insecure have lower overall diet quality, maladaptive eating habits that can lead to things like insulin resistance, obesity, and other cardiometabolic conditions. Another interesting pathway could potentially be through a stress pathway, where we know that being food insecure can lead to increased psychological distress, which in turn could lead to a biological stress response, which we know is a risk factor for cancer. So given all this, our group was really interested in really trying to understand what is the data on food insecurity and liver cancer and the link between these two factors. And we didn't really find a lot of kind of large-scale population-based studies that had looked at the link between these two factors. So we published this paper a few years ago now in IJERPH, where we did this exact analysis. And so this was co-led by my collaborators, Dr. Christelle Villefranc, Dr. Jasmine McDonald, and Dr. Wei-Chen Wu, who we've all worked together on this project and other liver cancer and food insecurity related projects. So for this specific analysis, again, we wanted to do kind of a large scale analysis looking at overall associations in the United States. So we turned to the Surveillance Epidemiology and End Results Program to capture data on liver cancer incidence rates. So I'm sure many of you are familiar with SEER, but for those of you who are not, this is a federally funded program led by the NCI that collates cancer registries across the United States into a harmonized data set, allowing for population-based analyses to be done using cancer registry data from across the nation. So it's harmonized data. You can look at both cancer incidence data as well as survival data. And for our analysis, we specifically looked at HCC, so hepatocellular carcinoma incidence rates, the leading cause of liver cancer, at the county level, and looked at whether or not this was associated with food insecurity. So we pulled our county level data from SEER. We looked at, we pulled counts by age of diagnosis, sex, and race ethnicity, as these were individual level factors that we were interested in exploring as potential modifiers for the association between food insecurity and liver cancer. So SEER is really great for getting population-based cancer registry data, But a limitation of using SEER is that there's usually limited data on kind of individual level or socioeconomic factors, and this includes food insecurity. And so we had to find an alternative source to get our information on county level food insecurity, given that it was not available in SEER. So for that, we turned to the Feeding America Mapping the Meal Gap Annual Report. So Feeding America is a nationwide hunger relief organization that releases this annual study where they actually measure food insecurity at the county level for every county in the United States. And so they do this using census level data. So every year, the census administers a survey that includes the core food security module on the survey for approximately 50,000 households. And so I won't go too much into the methodology of the specific survey and the sampling procedures, but basically this assesses food insecurity at the household level using a representative sample of the United States. Households with children get a slightly extended questionnaire compared to households without children, but how families are identified is that if they respond yes to 3 or more questions related to food insecurity, they're then classified as food insecure. So Feeding America takes this data from the US Census and uses it to calculate county level food insecurity using this sophisticated two-step approach that first estimates rates at the state level, then applies those rates to the county level to then provide county level estimates that can be used by the public. And so again, this is completely publicly available. So if you're interested in looking at or using this data for your own research, you can go directly to the Feeding America website and download this data. And they provide really nice technical briefs about the methodology behind their approach to measuring food insecurity. So I'd point you to there if you're interested in learning more about the specific details of this measure. But for our specific analysis, we took the county level food insecurity rates that were published by Feeding America for the years 2018 to 2021 to then calculate average food insecurity rates for this period for the counties that were included in our SEER data set. So once we had that county level measure of food insecurity, we then were able to merge that with our cancer data from SEER through linkage based on FIPS codes. So these are individual identifiers for every county in the United States. So you can use this identifier to merge different data sets that include this identifier. So this allowed us to link our cancer data with our food insecurity data and then conduct our analyses where we specifically tested whether or not our hypothesis of food insecurity being associated with HCC incidence rates was correct. So to look at the association, we use Poisson regression with robust variance estimation. I won't go too much into the details of the model itself, but I will say that we picked this approach because it allows you to control for the differences in county population size. As you can imagine, from state to state, the size of a population of a county varies. So that's an important factor to control for. And we also controlled for random effects for any state level factors that may be influencing our association. We then looked at associations adjusted for individual level factors, including age of diagnosis, sex, and race ethnicity. And then a second model that further adjusted for other county level factors, such as binge drinking, smoking, and obesity, which could potentially be covariates or potential mediators of the association between food insecurity and liver cancer risk. So getting straight to the results, again, this is a published paper, so if you want to spend more time looking at the table 1 and the descriptives, it is published online. But just to briefly point out some descriptives of our analytics sample, we did have just over 1,000 counties, including just under 39,000 cases of HCC diagnosed between 2018 and 2021. You can see 55% were diagnosed at age 65 or older. 76% of cases were male. Again, this is consistent with what we know about the etiology of liver cancer. And the average county level food insecurity rate was 12.9%. So fairly close to what we know in terms of, again, the national average for food insecurity households in the United States. And then again, maps are always a nice way to visualize your data. So here you can see where our counties are located in our specific analysis. And you can already start to see that there are some hot spots where you can see higher rates of county level food insecurities, particularly in the Southwest, down in Texas. And you can see a few hot spots correlating down below for the HCC incidence rates. So Then we moved on to our formal analysis where we looked at the association between county level food insecurity and incidence rates in our Poisson regression models. And so we first modeled food insecurity as a continuous measure, um, looking at overall if a one standard deviation increase in county level food insecurity was associated with liver cancer incidence. And as you can see here, we do in fact see a significant association, such that in the models adjusted for age, sex, and race ethnicity, a one standard deviation increase in food insecurity is associated with a 13% increase in HCC incidence rates. Adjustment for county level binge drinking, smoking, and obesity attenuated this association somewhat, but you'll see it's still statistically significant. We also looked at food insecurity categorized into tertiles just to check our assumption that this is a linear dose response relationship. And in fact, we do seem to have evidence that it does seem to be that with increasing levels of food insecurity, there is an increasing higher rate of HCC incidence. So we also wanted to look at the association stratified by different individual level factors. So we looked at whether or not the association between food insecurity and HCC incidence varied by age group at diagnosis. And interestingly, when we stratified by age group, what we found is that the association between higher levels of food insecurity and higher HCC incidence rates was observed among those less than 65 years at diagnosis. But when we looked at the older age group of 65 plus, there was actually no longer an association between food insecurity and HCC incidence. We also looked at associations stratified by stage of diagnosis, so localized, regional, and distant stage. And interestingly, we found that there was a significant association across stages of diagnosis, but the strongest effect estimate was found for distant stage disease. So as shown here, when you compare counties in the highest versus lowest tertile of food insecurity, those counties have a 41% higher incidence rate of HCC for distant stage disease. So to summarize the findings from this specific study, overall, we did find evidence of an association between higher county level food insecurity being associated with higher county level HCC incidence rates. Interestingly, when we stratified by different risk factor or underlying individual factors, we found that the association was specific to individuals under 65. One hypothesis for why this may be is that this could be due to differences in the age distribution of different underlying risk factors for HCC. So as I mentioned earlier, we know that the proportion of liver cancers attributed to viral infection is decreasing over time, whereas the number of risk factors related to lifestyle factors is increasing over time. So this could plausibly fit this hypothesis, although again, our data was in no way able to test this, so really requires further investigation. But I think it's important to note that this under 65-year age group does require some further attention in future studies looking at what's going on specifically in younger adults. And then this finding that a stronger association among distant stage disease could potentially point to the fact that food insecurity may be related to delays in diagnosis and access to healthcare or medical care and screening. But again, not a hypothesis we were able to test with this data. Interestingly, we didn't find that associations varied by sex or race and ethnicity, suggesting that food insecurity is important across these different subgroups. But overall, while we found an overall association, I think the next step is really now to start investigating using individual level data to really explore what food insecurity, how food insecurity is being linked to liver cancer risk. So I'm going to move now to the second study, unless there were any clarifying questions in the chat, which I can't see. So just unmute yourself if there's any questions before I move on.
I have a question, Becca. It's Adana.
Yeah. Oh, hey, Dana. Yeah, go
Really
ahead.
interesting work. I was thinking along the same lines as you about access to care and maybe even insurance. So I was gonna ask, is it possible to evaluate in like insurance coverage or some other area level measures that really gets at like neighborhood context, right? You're talking about food insecurity at the area level. So what other multi-level contributors might be also associated?
Yeah, no, it's a great question. And so the short answer for your question about insurance status is that that's actually not available in SEER currently. So you can't like control for or test insurance status as kind of an intermediate factor using SEER level data. So you could again look at other kind of neighborhood level variables that you could pull using census data to get at, percent of the county that's insured or the percent of the county that's below the federal poverty line. But the challenge, and I'll talk a little bit more about this in a later slide, is that getting that individual level data is very challenging using just SEER registry based data. But I think that's an important hypothesis that could be followed up potentially using other data sources beyond just SEER registry data.
Yeah, and I would say it's not just the individual level, because a lot of what this is multi-level
Yeah.
driver. So yeah, while an individual might be like confounders, I think that these m- um like community level and even more macro level measures, which they're not available in SEER, but I
Yeah,
think that what you're finding is really hypothesis generating that, you know,
exactly.
yeah. So thanks.
Yeah. Yeah, no, it's a great point. And like again, you're actually setting up very nicely for the next study where we look at another upstream factor. But I will just quickly comment that one of the real challenges with looking at all of these social determinants of health is that a lot of them are so correlated with each other, right? It's very hard to sometimes find like a food insecure county that then doesn't have high poverty. So teasing apart kind of the different factors that may be individually leading to cancer disparities is challenging. I mean, my argument would be that they're all working together to lead to disparities. But sometimes it's difficult to try to get that isolated effect of this is the effect of food insecurity versus insurance status and teasing them apart that way. But just in the interest of time, I think I'll keep going because I think this might actually address some of Adana's comments. Because we were actually had that same question of are there other factors and even more upstream factors from food insecurity that could be contributing to liver cancer disparities? And so this was actually a paper that was just recently published, led by one of my graduate students, Polly Wu, where we looked at census tract level persistent poverty. This time they're looking at liver cancer survival. And so exactly what Adana was just talking about, we know that these factors are related to each other, and there are potentially even further upstream factors that lead to factors like food insecurity, right? And so one of these is persistent poverty. So poverty kind of is the all-encompassing factor that really can contribute to these different healthcare access to food, education, and all interacting together. And so for this specific analysis, we are still, interested in food insecurity as potentially leading to disparities in liver cancer survival, but now thinking more upstream about persistent poverty as being the measure we look at. And so, again, I'm sure everyone on this call is familiar with the definition of persistent poverty, but here we're defining it as areas where 20% or more of the population has been living below the federal poverty line for 30 years or more. So it's important to note that this is an area-based measure. This isn't talking about individuals who have experienced chronic poverty over time. It's that there's been an area where a majority or a large portion of the population has experienced poverty over time. It can be defined at different levels of geography. So we can talk about county level persistent poverty or census tract persistent poverty, which would be at a finer level of exposure. And it's likely and it's thought that, exposure at these different levels can all be having effects on health outcomes. But the reason why we're really interested in studying persistent poverty specifically, and again, this is not new to this group, but we know that it reflects long-term structural economic disadvantage and that persistent poverty areas are characterized by sustained disinvestment in critical sectors, including education, healthcare, and economic development. And there's been quite a bit of work showing that being exposed to persistent poverty has an even greater or compounding impact on health beyond exposure to more recent bouts of poverty or areas that kind of are current or contemporary poverty areas. And so one of the first studies to look at the association between persistent poverty and cancer mortality rates was this study by Moss et al., published back in 2020. where they conducted an analysis very similar to what we did our ecological analysis for food insecurity, where they looked to see if counties that were classified as persistent poverty had higher rates of cancer mortality compared to counties that would be classified as non-persistent poverty. And so you can see in this figure here, they looked at several different cancer types, but including liver cancer. And you can see across the different cancer types, they do in fact see that persistent poverty neighborhoods have higher mortality rates for cancer than non-persistent poverty areas. But the really interesting analysis that I thought that they did was they looked to compare cancer mortality rates in counties that were persistent poverty compared to counties that had current poverty but didn't meet that threshold of persistent poverty. So they were currently considered in that poverty category, but they didn't meet that definition of having poverty for 30 years or more. And what they showed is that in fact, those persistent poverty neighborhoods still had higher cancer mortality rates compared to current poverty neighborhoods. So again, just supporting this idea that persistent poverty is an independent risk factor beyond just current poverty exposure. So this was a really important study, but as we know, there are limitations to these ecologic analyses where you're just comparing kind of county level rates to one another. And so we were interested in conducting an individual level survival analysis where we looked at whether or not living in a persistent poverty census tract was associated with with mortality risk among liver cancer patients. So for the second analysis, we once again turned to SEER for our liver cancer data. Again, though, this is now using individual level patient case listing data among those diagnosed with liver cancer. And for this specific exposure, I think it's been a few years now, but SEER has released this specialized data set where you can actually access persistent poverty census tract as an individual variable in their data set. So this is based on the address that someone lived at the time of diagnosis. SEER has since geocoded that address to census tracts and use census level data to categorize individuals as either being exposed or unexposed to a persistent poverty census tract at the time of their diagnosis. So this analysis actually didn't require outside data linkage. We could use all of the data specifically extracted from SEER. So for this analysis, we took liver cancer patients diagnosed between 2006 and 2019 with follow-up through 2020. So SEER is linked to the National Death Index, so you can look at vital status. So death can be obtained. And we looked at adults diagnosed between the ages of 20 and older with complete data on this census tract persistent poverty variable and other covariates, resulting in an analytic sample size of just under 74,000. So again, this is now an individual level analysis. So we performed Cox proportional hazards regression to look at the association between living in a persistent poverty census tract and mortality risk. Our primary outcome was cancer-specific mortality. 81% of deaths in our sample was attributed to liver cancer, which again matches with the fact that we know overall survival rates are quite low for this disease. But we did consider all-cause mortality as a secondary analysis. And then similar to our previous analysis, we did kind of a multi-step covariate analysis where we looked at how adjusting for different individual level factors impacted these associations, again, to try to start to understand what are potentially the individual level factors that may be interacting with or potentially mediating or confounding these associations between kind of these area level factors and cancer mortality. So again, these are published results. So these are just our table 1 data. So I'm not going to walk through all of the numbers, but I do think it's important to point out that just if you look descriptively, comparing individual level characteristics between liver cancer patients who were living in a persistent poverty census tract at diagnosis versus a non-persistent poverty census tract, you can see clear differences in individual level risk factors, right? So importantly, if you look at racial and ethnic differences, there are clear differences in the proportion of, for example, non-Hispanic, Black, and Hispanic individuals residing in persistent poverty neighborhood or census tracts compared to non-Hispanic white individuals. So again, I think that's important to point out why it's important to be considering these upstream social determinants of health when thinking through what's causing these racial disparities that have been documented previously in the literature. But we also see differences in stage of diagnosis as well as initial course of treatment between the different types of neighborhoods. So getting straight to the overall results, so these are just the basic Kaplan-Meier survival curves looking at unadjusted differences in cancer-specific survival and overall survival between persistent poverty and non-persistent poverty areas. As you can see, non-persistent poverty neighborhoods have a clear survival advantage over time compared to persistent poverty neighborhoods. If you just look at the 5-year survival rate, between the two, it's 31.3% in the non-persistent poverty areas compared to 24.8%. And we see similar differences when we look at overall survival rates as well. Again, not surprising that we see similar patterns for cancer-specific and overall survival, given that we know that the majority of the deaths are attributed to the cancer itself. We then looked at the association in our multivariable regression models to look at whether or not adjustment for these different factors has an impact on our effect estimates. As you can see in the unadjusted model, there's about a 19% increase risk of mortality when comparing individuals in persistent poverty census tracts to non-persistent poverty census tracts. Adjustment for these individual level factors really didn't have much of an impact on the effect estimates. The biggest attenuation was attributed to adjusting for initial course of treatment. But again, the association remains statistically significant even in our fully adjusted model. And then once again, we see very similar associations between cancer-specific mortality and all-cause mortality. So then we conducted our stratified analyses, and very interestingly, similar to what we found in the first paper, for when we stratified by age of diagnosis, we once again found that the association between persistent poverty census tracts and liver cancer survival was stronger in individuals diagnosed before the age of 65. So you can see here we have a hazard ratio of 1.14 for cancer-specific mortality and 1.17 for all-cause mortality. So again, really honing in on, we should be studying these kind of younger age groups, potentially separately from older age groups. We also looked at it by stage of diagnosis. So again, localized, regional, and distant stage. We did find evidence of of effect modification, although again, hazard ratios were significant for all 3 groups, but actually strongest here for localized disease when looking at liver cancer survival. So in this specific analysis, we once again found evidence that living in persistent poverty census tract was associated with higher risk of mortality among liver cancer patients. So this is consistent with what the Moss study found when they looked at kind of area level association or ecological associations. When you look at an individual level survival analysis, we see consistent associations supporting the hypothesis. We found some evidence possibly that treatment-related differences may explain some of the association, given that adjustment for initial course of treatment had the biggest impact on the effect estimates. However, I still would argue that we need better and more detailed individual level data to really understand some of the potential mechanisms explaining differences. And then again, I think it's interesting that we found this association being specific to those diagnosed before the age of 65. Similar to the first study, a hypothesis could be differences in underlying risk factors and morbidity between different age groups. But it's also important to note that now that we're talking about survival, access to Medicare may also be a potential factor that could potentially alleviate disparities in older age groups that have more homogeneous access to health insurance. So again, completely hypothesis generating, but I think an interesting area for further research. But overall, I hope with these 2 first examples, I've kind of given some examples of how we can use this administrative real-world data to link upstream social determinants to health disparities, including liver cancer disparities, using 2 different examples of food insecurity as well as persistent poverty as different variables to be considering and trying to understand liver cancer disparities. I very briefly, before going to the last part of the talk, want to talk a little bit about the strengths and limitations of using registry data. I think some of these have already come across, but I think it's important to note that there's some really great aspects to using databases like SEER, but also limitations to things like SEER when trying to understand health disparities and trying to understand the etiology and the role of social determinants of health. So really the real benefit of using these population-based and representative data sets is that they're just that. They're population based. They also have very minimal missing data. So SEER has over 98% completeness for malignant tumors. So you're really capturing an entire snapshot of cancers in a given registry's area. As I showed in the first paper, there are opportunities to link to other administrative data sets. And I think really the benefits to using these large population-based representatives data sets is they're really primed to allow us to identify where there's kind of disparities or high-risk subgroups of the population where cancer rates are increased, either across geography or across different demographic factors. We didn't talk a lot about or give examples of how we've looked at cancer trends over time using this data, but that's a really another big strength of using this registry data is you can look at trends over extended periods of time that can really point to when cancer incidence rates and survival rates have changed, and to allow us to think about what else is changing during those periods. And so really, where this all leads to is these are really great studies for hypothesis generation that can lead to thinking about, okay, what exposures do we need to look at in our individual level cohorts? So that brings us to the limitations of this type of data. Again, the number one really being that there's limited individual level data on key risk factors that we need. So this includes things like health behaviors. You don't have data on smoking or drinking or BMI in a cancer registry. We don't have really good detailed data on individual level socioeconomic status. And we don't have data on even area level factors beyond the area that someone lived in at the time of their diagnosis. So you don't really have that historical lens. Limited clinical data is another issue that we could talk about, especially when trying to really understand how differences in treatment and the quality of healthcare is contributing to disparities. And then timing delays in data availability really makes all of this together challenging to establish causality with these data sets. But again, I think these are still important resources that can really, especially in trying to understand health disparities, be used quite poignantly to really map what's going on in terms of cancer disparities. So I just wanted to last cover, and maybe I'll just go through this quick because I only have a few slides and then I can take questions. But I wanted to end by giving a brief example of how we can translate this real world evidence into action. Because again, as pointed on the previous slide, there's a number of limitations to using registry-based data, but it can also be really informative and can really provide the impetus to lead to kind of these more actionable and intervention-based research. And so this is one example of how our research team literally went from that first paper that we wrote to coming up with this idea for a food insecurity intervention among gastrointestinal cancer patients through a community-based intervention. So this was developed again with Dr. Christelle Villefranc and Dr. Wei-Chen Wu, along with Dr. Melissa Boscheman, who's a professor in the Department of Nursing and has done a lot of clinical work dealing with food insecurity among cancer patients. So this intervention we've developed, we've really been thinking about as this two-phased study where the first phase of the project has really been focused on integrating a food insecurity screener into the electronic health record at Columbia University Irving Medical Center's GI oncology clinics. So first we're focused on how can we identify food insecure cancer patients, and then the aim two or phase two of the project is then trying to identify a feasible and acceptable intervention that can actually connect these food insecure GI cancer patients to local community-based food assistance resources. So again, if you don't know who's food insecure, how can you intervene to help them? So that was really the impetus for our aim one, where we really focused on integrating this validated 2-item food insecurity screener into the patient flow of our GI oncology clinics. So these are the 2 questions that get added to the EPIC portal, so our EHR portal, that if a patient is going to check in for their GI oncology visit, they'll be prompted to complete this 2-item screener along with the other basic intake questions that they get asked. We did recognize that there could be potentially disparities or biases in our data if we only capture data through patients who complete the online EHR portal. So we do also have paper screeners available in the waiting rooms that are given to patients who had not completed the screener at the time of their appointment. And as mentioned at the beginning of the talk, we know that food insecurity is not a static exposure, and we know that individuals and households can move in and out of food insecurity. So we do have this screener prompted to be updated every 3 months for patients who are coming back for repeated visits. So we were successful at implementing the screener almost a year ago now. And based on this data, we found that about 18% of those who've completed the screener have screened positive for food insecurity. So again, this prevalence, should be interpreted with caution, given that, our denominator is probably not a complete population. But it is notable that we do see that food insecurity is a significant issue among a large portion of our patient population. So with this in place, we're now moving to the second phase of our intervention, where we're developing this community-based pilot study, where we're working with the community-based organization Westside Campaign Against Hunger, which is a large nonprofit food distribution delivery organization here in New York City that provides food distribution as well as food delivery free of cost to community members in need. They also provide support for benefits to access, such as enrolling in SNAP and WIC, as well as helping individuals with other services like shelter resources and financial counseling. And so our kind of approach was that instead of developing kind of intervention that was housed within our clinic, we would actually identify individuals in need in our clinic-based setting and then connect them to existing community-based resources, with the idea being that if we're leveraging resources that are already in place, this could be a more sustainable intervention. And so that's the phase we're at now, where we're actually going to test the original feasibility and acceptability of this intervention by conducting a small pilot intervention among 50 GI cancer patients here at Columbia that have screened positive for food insecurity. We'll then compare the impact of this intervention on factors like their current diet and eating habits, but also patient-reported outcomes, including mental and physical health-related quality of life, to see how having this reduction in food insecurity can have an impact on patient-reported outcomes. And so again, the intervention itself is going to be a direct handoff where a food insecure patient will be connected with a research coordinator who will then make the direct contact with the WISCA staff to ensure that they get enrolled in the resources they need with WISCA. And then these patients will also receive 3-month grocery delivery services through the WISCA's delivery services over a 12-month period. We'll then compare these individuals to a control group that will receive just a generic flyer, but will ultimately receive the groceries at the end of the study. So again, this is ongoing, so I don't have any results to present from this specific project, but I thought it was a good example to show kind of how we can take this kind of large real world data and apply it and use it to inform and support kind of our local and community-based research studies that are just as critical for addressing the social determinants of health. But with that, I'll just end with this quote by Gandhi that I think is particularly poignant when we're talking about food insecurity. But with that, I am happy to answer any questions about any of the studies or the pilot intervention that I presented. So thank you.